Neurology, pathology, headaches. All right, so let's break down headaches in a quick and easy manner. There's three separate types. You have tension, migraine, and cluster. So let's start off with tension. Tension is going to be, once again, a bilateral band-like distribution of pain, okay? If you see bilateral pain, you're most likely going to go towards tension, headache, okay? So that should kind of give you a hint. It usually presents mainly in females, okay? So females greater than males. And the onset is usually going to be under stressful circumstances. Okay. Once again, the location's a band-like pattern around the head. If you hear band-like pattern, start thinking of tension immediately. And the duration is not very helpful because it could be like 30 minutes to years on end. Okay. It's the most common headache, and it presents in like a constant dull pressure type of way. Okay. You're not going to have any types of aura. There's no photophobia. There's like barely any associated symptoms with tension type headache. And the reason I'm saying this is because you'll see that with the other migraine and cluster headaches, and that will help you differentiate them. But for tension headache, what I want you to take away is that it's a band-like bilateral pattern around the head. It's constant and dull pressure. It's the most common headache. It's more common in females. And honestly, you just treat it very easily with NSAIDs, okay? Not too high yield. Migraine, on the other hand, and cluster headaches are very, very high yield. So let's start off with migraines. Migraines are mainly in females, okay? So higher incidence in females. So that should give you kind of the number one hint, okay? It doesn't give it away right away, but it should give number one hint is that it's in females, okay? Number two is that the patient's gonna have like pulsating, pulsatile, and throbbing unilateral pain, okay? So pulsatile, throbbing, unilateral pain, all right? The duration will last anywhere from 4 hours to 3 days, okay? And it's usually it's going to have photophobia and phonophobia with potential nausea, okay? So it's going to be exacerbated by light and by sound, okay? And that's migraine. That should give you a very, very, very large hint that it's migraine, okay? And they want you to kind of know the pathophysiology behind it. It's potentially due to the irritation of cranial nerve 5, okay? They like you to know that, irritation of cranial nerve 5. All right. And it has something to do with release of vasoactive neuropeptide substance P and calcitonin gene-related peptide. I know that sounds odd, but it's something that you want to know. Okay. So you'll have increased cerebral excitability in a migraine, which leads to activation of cranial nerve 5, and that will lead to an increase in calcitonin release peptide. Okay. Or calcitonin-related peptide. All right. So keep that in the back of your mind for migraines. All right. Now the question is, how can you treat it? Acutely, you could treat it with NSAIDs and triptans. Okay. So triptans are like a serotonin receptor agonists. All right. And that can be used to treat migraines. You can also treat it with topiramate and valproate acid. Okay. Valproate. But overall, NSAIDs, triptans first, and then you could try topiramate and valproate for prophylaxis. Okay. They can help treat the migraine. All right. So just quick overview for migraines, relatively high yield. So incidence increased in females. The location is unilateral, okay? Unilateral, pulsatile, and throbbing in nature. Duration's like 4 to 72 hours. It has associated photophobia and phonophobia, okay, with nausea. And it's due to irritation of the cranial nerve 5, okay, which leads to increase in calcitonin-related peptide. You could treat it with topiramate and valproate for prophylaxis, or you could just give them acutely NSAIDs or triptans. All right. And then lastly, another high yield one is a cluster headache. This is more common in males, specifically male smokers. So the incidence is increased in males and male smokers. Okay. What you're going to be seeing is excruciating, sharp, and steady pain. Excruciating, sharp, and steady pain. They love to say it. They will call it like the suicide headache because it's so excruciating. And it's going to be located in the periorbital region. Okay. So you'll have periorbital pain right behind the eye. And it's going to happen 15 minutes to 3 hours, and it's going to be repetitive. Okay, so it will happen at the same time every single day. Like it will happen at like 9 a.m. every single day, something like that. Okay, and the symptoms are going to be associated with anatomic symptoms. Okay, or autonomic symptoms. Sorry. So you're going to have lacrimation, so tearing of the eye, dripping nose like rhinorrhea. You'll have conjunctival injection, so redness of the eye. That's all very, very important. You could also have ipsilateral autonomic symptoms of ptosis, meiosis, and anhidrosis from Horner syndrome. Okay, very key to understanding this is that it's behind one eye. It could be during sleep or similar times daily, like repetitive similar times daily, like every day at like 9 p.m. or something like that. It's more increase in male smokers, and it's excruciating, sharp, steady pain that's usually going to be behind the eye, right? Behind one eye. and it can cause lacrimation, rhinorrhea, conjunctival injection, and Horner syndrome. Okay, lacrimation is probably the most important out of all those. All right, very important. That all three of those are really, really important, but migraine versus cluster headaches is something that they love to test on. The way you treat cluster headaches, honestly, they don't really talk too much about it, but sumatriptan can be helpful, okay? Lastly is trigeminal neuralgia. Although not a headache, it's its own thing, but it is kind of clumped in together. Trigeminal neuralgia is very, 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 very painful. That's the one thing you have to take away from it, okay? It's like someone is getting electrical shock-like or stabbing pain in their face, okay? Now, the way that you can differentiate this shock-like and stabbing-like pain from cluster headaches, because cluster has shock-like, stabbing-like pain, right? Excruciating, sharp, and steady pain in the cluster headache, is that trigeminal neuralgia only lasts seconds rather than minutes to hours for cluster headache, okay? So trigeminal neuralgia lasts only seconds, and it's like electrical shock is something that they'll say, okay? And it's triggered by any light facial touch or facial movement. So if someone's chewing or talking, or if there's a gust of wind that hits their face, anything like that, and you hear that they have excruciating stab-like pain or shock-like pain that lasts a couple seconds, exacerbated by eating or talking or wind, then you know you're talking about trigeminal neuralgia. They want you to know the pathophysiology a little bit. It's due to compression of cranial nerve 5, right? Cranial nerve 5 root by an aberrant vascular loop, okay? They're not sure specifically, but this is what they think most cases are caused by, okay? Now, the way you treat it is carbamazepine. Carbamazepine is first line, all right? So overall, this is our headaches and trigeminal neuralgia. It's relatively straightforward. Just remember the difference in presentations of each one. Which sex is increased risk for incidence, and then look at like the characteristic type of pain that's presented with each one of them, all right? And you should be fine.